Often several screening tests may be applied in the same individuals, either sequentially or simultaneously. The results of these approaches are described in this section. In sequential or two-stage screening, a less expensive, less invasive, or less uncomfortable test is generally performed first. And those who screen positive are recalled for further testing with a more expensive, more invasive, or more uncomfortable test, which may have greater sensitivity and specificity. In simultaneous testing, we screen the population using two tests for this disease, test A and test B, at the same time. In sequential or two-stage screening, a test is performed first, and those who screen positive are recalled for further testing, which may have greater sensitivity and specificity. It is hoped that bringing back for further testing only those who screen positive will reduce the problem of false positives. Consider the hypothetical example in Figure 7a, in which a population is screened for diabetes using a test with a sensitivity of 70% and a specificity of 80%. How are the data shown in this table obtained? The disease prevalence in this population is given as 5%, so that in the population of 10,500 persons have the disease. With a sensitivity of 70%, the test will correctly identify 350 of the 500 people who have the disease. With a specificity of 80%, the test will correctly identify as non-diabetic 7,600 of the 9,500 people who are free of diabetes. However, 1,900 of these 9,500 will have positive results. Thus, a total of 2,250 people will test positive and will be brought back for a second test. Remember that in real life we do not have the vertical line separating diabetics and non-diabetics. And we do not know that only 350 of the 2,250 have diabetes. Now those 2,250 people are brought back and screened using a second test, such as a glucose tolerance test, which, for purposes of this example, is assumed to have a sensitivity of 90% and a specificity of 90%. Figure 7b again shows test 1 together with test 2, which deals only with the 2,250 people who tested positive in the first screening test and have been brought back for second stage screening. Since 350 people of the 2,250 have the disease and the test has a sensitivity of 90%, 315 of those 350 will be correctly identified as positive. Because 1,900 of the 2,250 do not have diabetes and the test specificity is 90%, 1,710 of the 1,900 will be correctly identified as negative and 190 will be false positives. We are now able to calculate the net sensitivity and the net specificity of using both tests in sequence. After finishing both tests, 315 people of the total 500 people with diabetes in this population of 10,000 will have been correctly called positive. 315 divided by 500 equals 63% net sensitivity. Thus, there is a loss in net sensitivity by using both tests sequentially. To calculate net specificity, note that 7,600 people of the 9,500 in this population who do not have diabetes were correctly called negative in the first stage screening and were not tested further. An additional 1,710 of those 9,500 non-diabetics were correctly called negative in the second stage screening. Thus, a total of 7,600 plus 1,710 of the 9,500 non-diabetics were correctly called negative. 9,310 divided by 9,500 equals 98% net specificity. Thus, use of both tests in sequence has resulted in a gain in net specificity. Let us now turn to the use of simultaneous tests. Let us assume that, in a population of 1,000 people, the prevalence of a disease is 20%. Therefore, 200 people have the disease, but we do not know who they are. In order to identify the 200 people who have this disease, we screen this population of 1,000 using two tests for this disease, test A and test B, at the same time. Let us assume that the sensitivity and specificity of the two tests are as follows. Test A with sensitivity equals 80% and specificity equals 60%. Test B with sensitivity equals 90% and specificity equals 90%. The first question we ask is, what is the net sensitivity using test A and test B simultaneously? To be considered positive and therefore included in the numerator for net sensitivity for two tests used simultaneously. A person must be identified as positive by test A, test B, or both tests. To calculate net sensitivity, let us first consider the results of screening with test A whose sensitivity is 80%. As seen in Table 3, of the 200 people who have the disease, 160 test positive. Consider next the results of screening with test B as seen in Table 4, whose sensitivity is 90%. Of the 200 people who have the disease, 180 test positive by test B. In Figure 8a, the oval represents the 200 people who have the disease. In Figure 8b, the pink circle within the oval represents the 160 who test positive with test A. These 160 are the true positives using test A. In Figure 8c, the oval again represents the 200 people who have the disease. The blue circle within the oval represents the 180 who test positive with test B. These 180 are the true positives using test B. In order to calculate the numerator for net sensitivity, we cannot just add the number of persons who tested positive using test A to those who tested positive using test B, because some people tested positive on both tests. As shown in Figure 8d, these people are shown in lavender by the overlapping area of the two circles, and we do not want to count them twice. How do we determine how many people tested positive on both tests? As seen in Figure 8e, test A has a sensitivity of 80% and thus identifies as positive 80% of the 200 who have the disease, 160 people. Test B has a sensitivity of 90%. Therefore, it identifies as positive 90% of the same 160 people who are identified by test A, 144 people. Thus, when tests A and B are used simultaneously, 144 people are identified as positive by both tests. Recall that test A correctly identified 160 people with the disease as positive, because 144 of them were identified by both tests. 160 minus 144, or 16 people, were correctly identified only by test A. Test B correctly identified 180 of the 200 people with the disease as positive, because 144 of them were identified by both tests. 180 minus 144, or 36 people, were correctly identified only by test B. Thus, as seen in Figure 8f, using tests A and B simultaneously, the net sensitivity equals 16 plus 144 plus 36, 200 equals 196, 200 equals 98%. The next question is, what is the net specificity using test A and test B simultaneously? To be included in the numerator for net specificity for two tests used simultaneously, a person must be identified as negative by both tests. In order to calculate the numerator for net specificity, we therefore need to determine how many people had negative results on both tests. How do we do this? As seen in Table 5, test A has a specificity of 60% and thus correctly identifies 60% of the 800 who do not have the disease, 480 people. As seen in Table 6, test B has a specificity of 90% and thus identifies as negative 90% of the 800 people who do not have the disease, 720 people. In Figure 9a, the oval represents the 800 people who do not have the disease. The green circle within the oval in Figure 9b represents the 480 people who test negative with test A. These are the true negatives using test A. Test B has a specificity of 90% and thus identifies as negative 90% of the 800 people who do not have the disease, 720 people. However, to be called negative in simultaneous tests, only people who test negative on both tests are considered to have had negative results. These people are shown in light green by the overlapping area of the two circles. Test B also identifies as negative 90% of the same 480 people identified as negative by test A, 432 people. Thus, as shown by the overlapping circles, when tests A and B are used simultaneously, 432 people are identified as negative by both tests. Thus, when tests A and B are used simultaneously, big 5 to 9F, the net specificity equals 432 800ths equals 54%. Thus, when two simultaneous tests are used, there's a net gain in sensitivity from 80% using test A, 90% using test B, to 98% using both tests simultaneously. However, there is a net loss in specificity. Net specificity equals 54% compared to using either test alone. Specificity of 60% using test A, 90% using test B. In a clinical setting, multiple tests are often used simultaneously. For example, a patient admitted to a hospital may have an array of tests performed at the time of admission. When multiple tests are used simultaneously to detect a specific disease, the individual is generally considered to have tested positive if he or she has a positive result on any one or more of the tests. The individual is considered to have tested negative if he or she tests negative on all of the tests. The effects of such a testing approach on sensitivity and specificity differ from those that result from sequential testing. In sequential testing, when we retest those who tested positive on the first test, there's a loss in net sensitivity and a gain in net specificity. In simultaneous testing, because an individual who tests positive on any one or multiple tests is considered positive, there's a gain in net sensitivity. However, to be considered negative, a person would have to test negative on all the tests performed. As a result, there's a loss in net specificity. In summary, as we have seen previously, when two sequential tests are used and those who test positive by the first test are brought in for the second test, there's a net loss in sensitivity but a net gain in specificity compared with either test alone. However, when two simultaneous tests are used, there's a net gain in sensitivity and a net loss in specificity compared with either test alone. Given these results, the decision to use either sequential or simultaneous testing often is based both on the objectives of the testing, including whether testing is being done for screening or diagnostic purposes, and on practical considerations related to the setting in which the testing is being done, including the length of hospital stay, costs, and degree of invasiveness of each of the tests, as well as the extent of third-party insurance coverage.